I actually had the chance to look over Lauren's slides a couple days ago. They were just phenomenal. So I thought what I might do is just try to give you my perspectives on some of the data that she presented. I just wanted to actually start by highlighting a couple of folks. And the first is actually Lauren. She's an outstanding speaker, as you all just saw. But I think that our interaction really highlights something that's a growing trend amongst young investigators in oncology. She and I interact frequently in the context of clinical trials. And we just had the Kidney Cancer Association meeting down the street from here over the past couple of days, and there's a pretty wide network of young investigators who are very interested in bringing these trials to fruition, and we're always more than happy to pick up the phone and call one another if we have trials that are relevant for our patients, and I think that's a really encouraging sign. So with that in mind, I'm going to jump into my presentation here, and this slide just offers a little bit of context with respect to where we've come in kidney cancer. This is a slide that may be familiar to many of you in one form or another. From 1992 to 2005, really the only treatment that we had available was interleukin-2, and over the past couple of years, we've really had a slew of targeted therapies approved in the clinic. So what are we discussing here in the context of the data? I just wanted to go over a couple of definitions here. We've talked a lot about response, and I think it's really critical to understand this. When we suggest that a patient has had a response, we're suggesting that their tumors have shrunk 30% or more in size. So assuming that this is somebody's baseline tumor, if it shrinks down by a factor of 35%, we would consider that to be a partial response. If it disappears completely, a complete response. If a tumor grows by more than 20%, that would be considered to be progression. So you see here that this tumor has grown from baseline by a total of 25%. That's a tumor that's clearly gotten worse, and a patient would, for instance, be taken off study on most accounts by virtue of that. And everything in between, everything between 30% and 20% is considered stable disease. So when we see 20% shrinkage, 10% growth, all of that falls under this umbrella of stability. Of course, if there are new tumors that pop up, that's considered to be a progression event as well. I also wanted to define this term progression-free survival because we're really going to be doing a deep dive into the data. And progression-free survival is an estimate that you see thrown in many press releases for drugs. What it really refers to is the point at which 50% of patients have had disease progression on a particular drug or agent. So we'll very oftentimes throw up these curves called Kaplan-Meier curves. This particular point here, where 50% of patients have progressed, we draw a line out towards the x-axis correlate, and this gives us a sense of how effective the drug is in delaying tumor growth. So with that background, I wanted to go through some of the challenges that we have with existing immune therapies. The problem that we had in yesteryear is that response rates to traditional immunotherapies like interferon were very, very low. So when we look at interferon as one example of that, the median progression-free survival, if we draw that line out here, was just on the order of around 3 to 4 months. And the median survival that we saw in the context of these studies was around 13 months. So this really established a benchmark about 10 years ago when we started exploring targeted therapies. Now, we're very fortunate to have in the room Peggy Zuckerman, who has followed me here from Los Angeles, and I'm just thrilled about it. She exemplifies what interleukin-2 can do. She's actually one of the folks who's had an outstanding response on this curve here. But what I would suggest is that the cumulative response rates to interleukin-2 are relatively low. They're somewhere in the ballpark of 7 to 12%. And in addition to that, we don't really know who benefits from the agent. And I would suggest that interleukin-2, although Peggy, for instance, has done exceptionally well, does carry with it some mortality risk, some substantial cardiovascular disease that can occur with it. So this is what I perceive as being the dilemma with the existing immune therapies. Some patients who receive these immune therapies, who are noted here in green, do exceptionally well for a very, very long period of time. And I would love to figure out who these folks are. The challenge is that if I give patients interleukin-2, there's a chance that 1 or 2 of those patients may actually succumb not to the disease, but to the therapy. And I actually don't know how to predict who those individuals are. And for the vast majority of individuals in this room, interleukin-2 does not carry benefit. So what about the targeted therapies that we have now? I think this is a kidney cancer savvy audience. We're all familiar with Sutent, with Afinitor, with some of the other agents that we have at our disposal. What I usually like to suggest is that if I treat a population of 100 kidney cancer patients that are noted here with a drug like Sutent, we're going to have about 40 who have a good response. And these patients will typically be on the drug for a prolonged period, but certainly not an indefinite period of time. We're going to have another 40 folks who have stability of their disease. So again, their tumors don't shrink by more than 30%, but they don't increase in size by more than 20%, and they don't have any new lesions pop up. And we've got still a number of patients, about 20 folks in that room of 100, who are going to have no response to therapies. The challenge is that with Sutent, as I highlighted previously, you're still going to have everyone ultimately progress on the treatment by and large and need to move on to subsequent lines of therapy. So what I wish I could do, again, is to tease out the individuals in this room who are going to have that exceptional response to interleukin-2 therapy. And in fact, there have been efforts to do this. So Mike Atkins, who you just heard from in the last session, was actually one of the leaders of this study through the cytokine working group called the SELECT trial. So in this study, 126 patients were assessed. And the goal here was really to identify whether or not we could identify the features that correlated with these outstanding responses. So we looked at the risk group of the patient, if they had good risk, intermediate, or poor risk, and this is defined by clinical characteristics, how healthy the patient was at the time of study entry, what their underlying laboratory values were. This didn't seem to be predictive. We also looked at a laboratory called CA9, and there was a lot of hope that CA9 might potentially pick out those individuals who are going to have a really robust response to interleukin-2. That really didn't pan out in the study. So what I would suggest is that when I see a patient with newly diagnosed kidney cancer in my clinic, I still can't pick out who's going to benefit from interleukin-2 therapy. But really the way the future in terms of immune therapies, Dr. Harshman suggested, is PD1 inhibitors. She also touched on vaccine therapies as well. And of course, all these therapies in a cumulative fashion really harness the T cell in a much more specific fashion than interleukin-2 and interferon did. So I just wanted to go over the data that we have to date, because a lot of folks will come into the clinic really just insistent on getting a PD1 inhibitor, and I don't at all think that that's unreasonable, but I just wanted to perhaps couch the expectations for immune therapy with some of the data that we have at hand. So this is the phase 1 data that was presented at ASCO multiple times over the past several years, and this included a hodgepodge of different patients with kidney cancer, lung cancer, et cetera, and we've had a deep dive into the data here with respect to patients in this phase 1 experience that had kidney cancer. So about half of patients had multiple lines of therapy previously, Sutent, Definitor, et cetera, and the median survival in that cohort at the time of this last data presentation hadn't been reached. So at 2 years, 50% of patients, despite having multiple therapies, were still alive. So that's incredibly encouraging. And when you look at the response data here, 29% of patients, so again, 29 folks in that room of 100, had that 30% or more decrease in their tumor volume. So that was quite impressive. And maybe the most impressive piece of the data that we had from the phase 1 trial is that the responses really lasted well beyond the duration of treatment. So you could actually stop nivolumab therapy, you could stop the PD1 inhibitor, and still have a sustained response, which is really quite impressive. So what did this data pan out to be in the phase 2 experience? So this is the phase 2 study that Dr. Harshman had highlighted and showed you data from just a moment ago. So this explored 3 dose levels of nivolumab therapy, a low dose, intermediate dose, and a high dose here. And patients were randomized in a 1-to-1-to-1 fashion. And what we saw here was a progression-free survival that ranged from 2.5 to 4 months. So in my mind, this wasn't particularly impressive. So when you juxtapose that against the close to 7 months that we saw from the phase 1 data, again, it's perhaps a little more underwhelming. But of course, I think that one of the things that stood out in this trial is the response rate. And as Dr. Harshman had indicated, we're really focused on this group of individuals here who have had really robust responses to these drugs, and oftentimes these responses can be sustained. But I will point out that we saw a response rate of close to 30% in that phase 1 experience, and here as we go to phase 2, perhaps a less carefully selected group of patients, we see that the response rate is down to close to 20%. So what about picking the right patient for PD1-based therapy? And I have a session right after this that's really going to focus on that in a little bit more detail. One of Dr. Harshman's colleagues at the Farber, Dr. Choueiri, presented this data at ASCO this past year. And this was a complicated design, but fundamentally, I think, mirrored what we saw in the previous study. Again, several doses of nivolumab therapy. And they did biopsies at baseline and biopsies at several weeks into the course of therapy. And this allowed us to compare PD-L1 staining in these patients. Dr. Atkins just gave a very nice overview of the potential role of expression of PD-L1 as it pertains to response to these drugs. And I was a little underwhelmed when I saw this. So whereas in some diseases like bladder cancer, and I'll highlight this in the next session, we really see some nice correlation between the amount of PD-1 and response. Here, what we saw is that PD-L1 positive patients had a response rate of 22%, and PD-L1 negative patients had a response rate of 8%. So my comment here is that even if your tissue stains PD-L1 negative, I'd still have some reservations about turning you away from a PD-L1 based trial. And similarly, if you're PD-L1 positive, I can't necessarily say that these drugs are going to be a home run, that your response rate is going to be markedly discrepant from somebody who's PD-L1 negative. I also wanted to just give you a broad sweep of the data here, and I'll point out again, we saw a progression-free survival of 7 months in the phase 1 experience. Again, now we're down to 2.5 to 4 months as we look across the phase 2 data set. We saw a response rate of 29% in patients that were in the phase 1 experience, and these were patients that had gotten multiple prior lines of therapy. And here we see the response rate is down to 20%, and in fact, in one specific population of patients that I want you to focus on here, these are 24 patients in Dr. Choueri's trial that had no prior therapy, the response rate is actually down to 13%. So, you know, it's impressive data that we've seen to date with this compound, but again, I just want to urge some caution in interpreting this. So my key take-home from this particular data set is that the data that we have for looking at PD-1 monotherapy is very preliminary. The phase 1 data, in my mind, seems a little bit better than the phase 2 data, and based on what I've seen so far, I don't really think that we can use your PD-L1 status to really predict benefit from nivolumab therapy. So I'm going to wrap up here by saying that there's no real good reason to fly to Japan to get nivolumab where it's approved. And I'd also say there's no point right now in getting lambralizumab off-label. These are real conversations that I've been having in the clinic with my patients. It's easier to fly to Japan from Los Angeles, so maybe that's why we're having those discussions. And Dr. Harshman gave a great overview of this combo study looking at several different combinations of nivolumab with either a VEGF-directed therapy like sunitinib or pazopanib, or ipilimumab with nivolumab, which again takes two of these immune mediators and throws them together. So we actually participated in this trial, and I had a number of patients on. And again, this is the data, which is quite impressive. I'm going to jump to this waterfall plot here that Lauren had highlighted, and just mind-boggling to see this level of response. It was incredibly, incredibly impressive to see patients respond in this fashion to this combination of agents. But with that in mind, one of the really concerning facets was the toxicity, and Dr. Harshman already alluded to this. And there are two in particular that stood out to me, and these were things that I dealt with in the clinic that I was quite concerned about, in fact. And these include gastrointestinal toxicities, principally diarrhea, and also liver-related dysfunction. And the rates were quite high. So if we look at, for instance, patients who got sunitinib in combination with nivolumab, we see that the rate of liver dysfunction is around 27%. The rate of GI toxicity is around 10%, and this is grade 3-4 toxicity. I'm going to point this out in a little bit more detail in just a moment. With pazopanib plus nivolumab, even more concerning, about a 40% rate of grade 3-4 liver toxicity, 20% rate of GI toxicity. So what is grade 3-4 toxicity? You can see that I've sort of skimmed over the all-grade toxicity over here. Grade 3-4 toxicity is the type of toxicity that, in my mind, really deserves specific and immediate attention. So Lauren and I and Marianne, we all carry around these little pocketbooks that define, the grade of toxicity and how it relates to the symptoms that you're experiencing in clinic. So grade 1 diarrhea, I wouldn't say is at all clinically insignificant, but a patient would be having less than 4 stools per day. Whereas with grade 3 diarrhea, you're actually having more than 7 stools a day. This could potentially require hospitalization, and grade 4 toxicity implies life-threatening consequences. So grade 3-4 toxicity is nothing to dismiss. This is really, really serious toxicity here. Similarly, with respect to liver function tests, and this is maybe a little bit harder to articulate because we're just looking at numeric values here, but if you have grade 1 liver toxicity, it means your AST and ALT levels, and you guys have probably seen these on lab reports, will go up to 3 times the upper limit of normal. With grade 3 toxicity, they can go anywhere from 5 to 20 times the upper limit of normal. So this is an incredibly broad range. And I have to tell you, we're just a couple of steps away from liver failure when we get into this range, unless it's managed very quickly and appropriately. So again, grade 3-4 toxicity is really, really bad. And what about this combination of nivolumab with ipilimumab? And again, Dr. Hartman pointed out the fantastic data that we've seen to date. Several of my patients have benefited tremendously, from this combo of drugs in the clinic. But I'll say again here, I have my reservations about toxicity. These are two very small groups of patients. In my mind, it's probably better to lump these two together. And if we look at the cumulative rate of grade 3, 4 liver-related toxicity, we see that it's around 26%. If we look at the GI toxicity, around 22%. So again, pretty high rates of grade 3, 4 toxicity. Now, the company has made the conscious decision of moving forward with just this arm. And if you look here, the rates of grade 3, 4 toxicity are a little bit lower. But this is just based on 20 patients. So there are many skeptics who say that, when this particular regimen gets fanned out, not from academic centers, but into community centers, you might see actually an amplification of this toxicity. When Lauren and I and Marianne give these treatments in the clinic, and please jump in if your experience has been different, but I actually have the medical monitors for the clinical trial on the phone all the time. I have them on speed dial, and in fact, my patients have my cell phone number, so it's an immediate segue into experts who know how to manage these toxicities. When these clinical trials go out to sites that are perhaps a bit more remote, that don't have immediate access to toxicity management, I can potentially see the rate of grade 3, 4 toxicity getting amplified because we're actually not catching these toxicities at grade 1 or grade 2. So that's something that really concerns me. And this is, I just threw this in there and said, because this really kind of bewildered me. We've talked about maybe PD1 patients, PD-L1 positive patients not having as high a response rate as we might expect in the context of nivolumab monotherapy. With this combo of drugs, everything is completely thrown here. Because what we see is that if you're PD-L1 positive, in point of fact, your response rate is actually lower than if you're PD-L1 negative. And I'm going to go through this data in a little bit more detail in the next session. But again, we can't use PD-L1 status in this particular case to predict activity. So the key message here is that grade 3, 4 toxicities really shouldn't be underestimated. At our academic meetings, one of the gripes I always have is that we throw up the toxicity data for literally 10 seconds and move right on into efficacy. I think this really needs to be paid attention to. Again, we did these studies in academic centers with a ton of experience, and I just wonder whether or not the toxicities are going to be amplified when we move elsewhere. And also, I would just again add that we don't know about the utility of PD-L1 staining with single-agent nivolumab, and we know even less about the utility of PD-L1 in the context of the combination therapy. So again, the response to targeted therapies isn't necessarily bad, and what we hope to do is really combine a targeted immune strategy to turn everybody into a long-term durable responder, but I don't think that we're there yet. I really still think we need to participate in clinical trials. So this is the lineage of studies that we have at City of Hope. One of the unfortunate realities of the situation is that we don't have, and correct me if I'm wrong here, Marianne and Lauren, we don't have a lot of PD1 and PD-L1 directed studies that are available now for heavily refractory patients, patients that have been exposed to 3 or 4 prior lines of therapy. Our best opportunity to give PD1 and PD-L1 directed agents is up front. And so that's why folks like Peggy and folks like Carly, who are out there disseminating information to patients, are so key. We really need to increase the bandwidth of this information so we're getting folks into these first-line PD1 and PD-L1 directed studies. But at the moment, no good reasons to fly to Japan for nivolumab and no reason to spend big bucks to get Lambro off-label. Thank you.